Hi, I'm Marlene Moster from Wills Eye Institute in Philadelphia. It's March 2011, and the program committee gave me the choice of interviewing Tom Cruise or Dr. Richard Wilson. Of course, I chose Dr. Wilson because he's so much more exceptional. So, Dr. Wilson, tell us, why did you go into the field of glaucoma, and who were your mentors and role models?
Well, I think it's all comes down to George Spaeth. When I got to my senior year rotation in glaucoma in 1977, I had no thought of going into glaucoma. In fact, the glaucoma clinic at Wills at that point was pretty depressing for the first and second years, who could only offer medical care, which was at that time pilocarpine, phosphate iodide, epinephrine, and Diamox. And as you remember, those had such bad complications that it was hard to keep the patients taking them. And the patients had, most of them had fairly poor socioeconomic status, so that made the follow-up kind of spotty. And both factors combined to sort of force them having an inexorable downhill course. So I thought anybody going into glaucoma should have their head examined. And then I hit glaucoma surgery. And I found that challenging. And it seemed like even if I did the procedure perfectly, I could still have a disaster as an outcome. Occasionally I would do it, and I would be kicking myself for days afterwards because the patient, I thought I could have done it so much better, and yet the patient did pretty well. So there are obviously quite a few factors that are outside my control. And that element of chance really made the surgery so much more challenging and rewarding than more predictable surgeries. If you couple that with a young George Spaeth who is enthusiastic about everything glaucoma and who is a very aggressive and skillful surgeon and who would try anything once, and that month changed my career. I wanted nothing more at that point than to be a glaucoma specialist.
Excellent. What do you think are some of the most significant advances in the field of glaucoma that has happened during your career?
Well, for a career, it's kind of hard to encompass all of those. I could, run through all the different procedures that we've come up with. It seemed like for the longest time, we were not making any strides in understanding the disease. It seemed like decades went by before we really started to understand more about the pathogenesis and somewhat about the genetics, which has really happened in the last 5 to 10 years. What I'd kind of like to do is to maybe discuss it from a little different aspect, which would be the quality of life of the glaucoma surgeon. I know my son would think I'm an old fuddy-duddy for just bringing the subject up, but I don't think the young glaucoma specialists these days really realize how much their quality of life has improved as the quality of care they've been able to offer has improved. As you remember, Marlene, when I was in my early years at Wills, my nickname was Doc Holliday, and that was because most holidays found me in the Wills operating room as well as a good number of Saturdays. And the reason was fairly clear. The treatment for angle closure glaucoma, acute angle closure glaucoma, was surgical PI, and between 3 and 4% of my patients required a reformation after a trabeculectomy with a drainage of the choroidal detachment. And that was best done on the fourth post-operative day. So I made sure my operative day was Tuesday so I could do my reformations and drainages on Saturday without interrupting my patient hours. And remember that those days, all surgical patients were inpatients, so that in spite of the fact I had residents and fellows to help me, I would usually spend about 45 minutes in the morning before outpatients doing rounds, and then again in the evening, another 20 to 30 minutes. And so it really lengthened the day. When argon laser came in, I spent less time in the operating room, but it was so easy to cook the endothelium if you just concentrated on trying to shoot your way through the iris, that it generated a column of superheated aqueous in the convection current. And I didn't feel comfortable not being with the resident or fellow until later in the year when I could get confident in them. When the YAG came in, that made a big help. But I still spent a lot of time in the operating room on weekends. The thing that really made the most difference was releasable sutures and laserable sutures, which allowed the surgeon to lower the intraocular pressure in a stepwise fashion after surgery. And that really reduced the flat chambers to almost a rarity and made my life a whole lot easier and my patients a whole lot happier. And remember those depressing glaucoma clinics that I talked about earlier? You know, with the advent of medications that you use once or twice a day that had far fewer side effects, it was much nicer for the glaucoma specialist because he had to spend much less time cajoling the patient into taking medications that the glaucoma specialist knew were decreasing their quality of life. So I just thought I could put in a plug for the young glaucoma specialists, getting them to kind of realize how far and how many advances there have been in glaucoma that have really improved their quality of life as well as the quality of care that they can render to the patient.
Dr. Wilson, what do you think your contributions specifically in the field of glaucoma have really furthered the field?
Well, I think there are kind of two kinds of contributions. One is if you're lucky enough to be in the right place and you're lucky enough to recognize what's going on and you just report it. And some of my contributions in that regard would be the first paper on the use of timolol in secondary glaucomas, the first description of an encapsulated bleb, which I did at a NEOS meeting, the first description of AIDS as a cause for secondary glaucoma, the first description of viscoelastics in filtration surgery, the first description of using 5-FU or antifibrosis agents to obtain really low pressures as needed for normal tension glaucoma. And that series had an average of 6.9, which I think may still be the lowest average pressure for a surgical series. And then finally, the use of aqueous shunts in infants. Then there's another kind of contribution where you're faced with a situation and come up with a way to solve it that others faced with that same situation may not. When we moved from doing intercaps with psychodialyses and phosphine iodide for life to doing extra caps with a PCIOL and trabeculectomy for our combined procedures, that added a lot of stress to my life, because if you had a shallow chamber, a flat chamber, and you had the lens coming forward and touching the endothelium, you could get corneal decompensation. So when I was leaving the hospital at night and I'd seen the patient on morning rounds and evening rounds and the chamber was gradually shallowing, it would cause me a fitful night's sleep, wondering whether the morning I'd come back and the patients would be shallow or flat and the endothelium already on its way out. So I remembered Bill Simcoe's technique for a chamber retaining suture where he would use a horizontal mattress across the anterior chamber in order to insert an IOL in his cataract extraction in the pre-viscoelastic days. So I adapted his procedure, made it much easier using long needles that could bridge the anterior chamber, and experimented with several different types of suture, and found that nylon was required in order to resist the effects of an expulsive hemorrhage. And so by adding a minute of time and putting this horizontal suture across the anterior chamber of the eye, kind of bowing the cornea up a little more than normal, I could sleep normally at night because I knew no matter what happened, the IOL was not going to hit the cornea, and I could sleep better. It didn't do anything for the choroidal detachments that we got, and it was clearly problematic if at the time of surgery you had to develop a big enough fistula that after all the healing and scarring had taken place, you still had a big enough fistula to give you an adequate pressure for the patient. So that was what caused that 3.5% flat chamber rate for me. And I was thinking that if I could just develop a stepwise way to lower the intraocular pressure after surgery so that the eye could adjust to the lower pressure without developing a choroidal detachment, then that would be very helpful. So that's when I came up with the releasable suture that could be placed at the time of surgery and taken out if you had two, in a sort of a stepwise fashion to lower the pressure. And with that, and then laserable sutures and the Osher-Cohen releasable suture, flat chambers became almost a rarity, and happy patients were much more common. And then I was lucky enough to be a consultant to Surgical Laser Technologies. And as you remember, they had a proprietary technology or proprietary coating that they could put on the end of their synthetic sapphire crystals that would absorb the laser energy so that the laser effect would be right at the end of the crystal, right at that crystal tissue interface. And by varying the shape of the crystal, they could make it more of a thermal, cautery type of energy that was put out, or if they focused it very finely, they could have a vaporization cutting effect. So I had them make me two long crystals, one with a 200 micron end, one with a 400 micron end, and I could insert those across the eye through a 3 millimeter incision after filling the anterior chamber with viscoelastic, and also injecting viscoelastic under the conjunctiva to protect it. And then I could make a laser sclerostomy ab interno, and this was very good in the inferior 180 degrees as well as superior 180. So if there was scarring in the superior 180, I could access all the inferior 180 degrees. So these patients were the first laser sclerostomies in humans. And many of them worked very well. One I know worked for at least 15 years and kept the patient well controlled. However, it suffered from the same kind of problems as say an express shunt without using a flap, in that it was a full thickness procedure. So you did get more choroidal detachments. And because the technology was expensive, it was never widely adapted. And finally, I'd like to think that some of my achievements as president of the American Glaucoma Society were meaningful. I think my major achievement was to make the AGS less of an old boys club, opening up the management for input and participation by the wide range or spectrum of the Glaucoma Society membership. I also liked to call attention to all the myriad of talents that we had in the membership that were outside of medicine, and the hobbies that many of the members pursued quite passionately, and those resulted in the AGS Avocation Day and the AGS Band.
Excellent. What advances do you think will occur in the near or distant future that will really advance the field of glaucoma research or patient care?
You know, I think that looking mostly at patient care rather than bench research, I think we'll come up with advances that benefit the less advanced part of the spectrum of glaucoma, and even the patients that are at risk but have not developed definite damage, and therefore we don't know to have glaucoma yet. One of the hardest things for the glaucoma specialist is when he's confronted with a new patient and doesn't have an IOL or an IOP history to try to decide what the target pressure is. Most often we wait to see if they get damage, and then we lower their pressure 25 to 35% and wait to see what happens. And if they get more damage, then we add more therapy. And that just consigns a proportion of our patients to getting worse before we do something. I'm hoping that we can, when our patients come in,